On that note, local anesthetics, of course, when given at doses higher than recommended, can cause toxicity. So while you get analgesia at low plasma concentrations, as your plasma concentration increases, you start to get escalating signs and symptoms of toxicity, which you should probably know in order of what you'll see. So the first thing you'll see is tinnitus, perioral numbness, sometimes a metallic taste in the mouth. Then with slightly higher plasma concentrations, you'll get CNS excitation and seizures. This can be heralded first by muscle twitching and then actual seizures. This is followed then by CNS depression and coma, and then cardiovascular depression and cardiovascular collapse. So with lidocaine, there is at least a pretty large separation between the plasma concentrations that are therapeutic and those that will cause cardiovascular depression. So this is plasma concentration in mics per mil. So less than 5 is usually safe and can be therapeutic. The tinnitus, perioral numbness, everything will happen around 5 to 10 and so on until you get to coma and then cardiovascular depression. But let me show you that it's actually maybe not that hard to get to these higher plasma concentrations using what you may think is a safe dose of a local anesthetic, depending on how quickly it reaches your blood vessels and therefore your brain and your heart. So let's take an epidural injection of lidocaine. This is going to be 400 milligrams, which is kind of a high dose of what you may top someone up with for a C-section. It has been shown that at about 20 minutes, you'll reach your peak plasma concentration just around 5. So sort of the upper limit of what would be a therapeutic plasma concentration for lidocaine. Whereas if you take that same 400 milligrams and accidentally inject it intravascularly, so into an epidural vein or in through the patient's IV, you're going to have a very quick rise in the plasma concentration. It will be much higher than 5. And I don't know exactly how high this will go, but it will be certainly well into the toxic range. To put this into perspective, there are indications for giving about a 1.5 milligram per kilogram bolus of lidocaine around the time of induction for a general anesthetic. And so that's going to be way less than this 400 milligrams. That might be 100 milligrams. And almost every time you do that, if the patient is not sleepy, they will have the signs of toxicity in this sort of plasma concentration range. So tinnitus, perioral numbness, or metallic taste in their mouth. This is why you always aspirate before you inject, because you want to make sure you're not injecting a large dose of local anesthetic directly intravascularly. The rate of systemic absorption depends where the local anesthetic is deposited. I mean, obviously, if you inject it intravascularly, then it is now an entirely systemic dose. So that's at the top of the list. And then tracheal, intercostal, paracervical, epidural, brachial plexus, sciatic, and subcutaneous finally at the end. This primarily has to do with the vascularity of these anatomical locations. We talked about this before, but these highly vascular areas will have local anesthetic quickly leaving whatever area you put it in, just hopping into your bloodstream and being taken away for metabolism. So these areas you'll have, in general, a shorter duration of action of your local anesthetic because it's leaving into your bloodstream, and then you'll have high and early peaking of your plasma concentration. Whereas when you have low vascularity, you'll have later peak, which will be low because it's more spread out.